Hello my dear curious and studious students of surgery, myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome my dear students in my surgery lecture number 103, that is the mediastinum and diaphragm, the heart and the pericardium. In this lecture, we will explore the mediastinum, the mediastinal emphysema, mediastinal tumors and cysts, the diaphragm, diaphragmatic hernia, the heart and the pericardium, cardiac arrest and its treatment, investigations for heart disorder, congenital heart diseases, cyanotic congenital heart disease, cyanotic congenital heart disease, acquired heart disease, the pericardium and the pulsus paradoxus. All these points will cover and explore in this lecture. Now we start with the mediastinum. First we see the anatomy. The mediastinum is an extrapleural space between the two pleural cavities, border on each side of the parietal pleura. It is customary to divide mediastinum into the several areas. The mediastinum is classically divided 4 compartments, that is the superior mediastinum, which lies above the plane extending from the lower margins of the manubrium sterni, and second is the anterior mediastinum, lies in front of the anterior border of the heart, and third is the middle mediastinum. It is a triangular area with its base on the diaphragm and is bounded in front by the anterior mediastinum, and the fourth is the posteriorly. It is bounded by the anteriorly by the middle mediastinum and posteriorly by the anterior border of the bodies of the dorsal vertebrae. Now there is the boundary of the mediastinum septum of the thorax between two lungs. Boundaries of this mediastinum are anteriorly sternum, posteriorly vertebral column, superiorly thoracic inlet, and inferiorly mediastinal pleura. Division of the mediastinum is the superior mediastinum and inferior mediastinum. Inferior mediastinum subdivided by 3 types: anterior mediastinum, posterior mediastinum, and middle mediastinum. Dear students, here is a good picture showing the diaphragm, which I describe you. The surgical anatomy of the mediastinum is clearly seen in this picture. The branches of the aortic arches, sternal angles, sternal body, xiphoid process is there, diaphragm, and inferiorly, posteriorly, and anteriorly side of the mediastinum is clearly seen. Now this is the second image where the subclavian artery and vein is clearly seen. Left common carotid artery is also seen. Left pulmonary artery, left pulmonary veins, bronchi and aorta is clearly seen. Now the mediastinal emphysema. Introduction of air into the mediastinum produces mediastinal emphysema or pneumomediastinum. The air usually comes through the rent in the tracheobronchial tree or in the esophagus. Penetrating wound, injury, these structures or blunt trauma with fracture of the ribs and vertebrae may rarely cause such injury. Now, spontaneous mediastinal emphysema, in which the air leaks out into the mediastinum, are not following trauma but easily following the interstitial emphysema of the lung or due to the alveolar rupture following positive pressure ventilation. Air by dissecting along the vascular structures of the lung enters the hilum and then into the tissue planes of the mediastinum. Now, the clinical features, symptoms, pain and crepitus in the suprasternal notch and in the neck. Physical sign is crepitus in the sternal notch. Chest X-ray is a diagnostic. Treatment is surgical decompression, ICD, intercostal drainage with water sealed bag, thoracotomy if needed, and antibiotics should be covered. Now here is a typical picture of the mediastinal emphysema is clearly seen, where the air leaks usually to the rent of the tracheobronchial tree, and air is clearly seen in the mediastinum. Now this is the second image showing the mediastinal emphysema. This is the CT image showing the leakage of the air to the tracheobronchial tree. Now the mediastinal tumors and the cysts. The various tumors and cysts which are noticed in the mediastinum are as in the superior mediastinum. This is the thymoma in the most common, followed by tumors of the thyroid and tumors of the parathyroid in the anterior mediastinum. Retrosternal, goitre, Thymoma, Teratodermoid tumors, germ cell tumors, lymphomas, parathyroid adenomas, lymph node lesions, Mesenchymal tumors. Dear students, here is the CT image showing the mediastinal mass clearly showing. Next is the tumor of the mediastinal. In the middle mediastinum, mainly the cyst, that is the bronchogenic cyst and pericardial cyst. Fourth is in the posterior mediastinum, neurogenic tumors, which are by far the most common, and enteric cyst. Neurogenic tumors is a neurolymphoma, enteric cyst, neurofibroma, pericardial cyst, ganglioneuromas, and phlebochromocytomas. Now the diaphragm, development of the diaphragm, that is the closure of the pleuroperitoneal Opening is caused by a mesodermal partition which separates our thoracic from the abdominal cavity and form the diaphragm in the adult. The diaphragm is developed from composite structures of which the septum transversus is the main and caused by the mesodermal portion separates thoracic from the abdominal cavity and forms the diaphragm developed from the septum transversum. Developmentally, diaphragm is the composite structures of the pars diaphragmatica of the septum transversum, pleuroperitoneal membrane, gastrohepatic ligaments, that is the pars mesenterica, the dorsal mesentery, mesoderm of the dorsal body wall and costal portion of the chest wall. Dear students, here is the image of the diaphragm which is showing the caval hiatus, central tendon, the sternal attachment, esophageal hiatus is there, aortic hiatus is there, and vertebral attachment posteriorly is clearly seen in this diagram. Now second diagram showing the pericardium and the diaphragm, the dome of the diaphragm. Now the diaphragmatic hernia. Basically there are two types of the hernia, one is the congenital and second is the acquired. In the congenital hernia occurs at the certain well recognized point due to the failure of the fusion of the various elements which make up the diaphragm. Such hernia usually has a well defined peritoneal sac and adhesions around this type of hernia are uncommon. Congenital type is through the esophageal hiatus, through foramen of the monoagni, retrosternal, through foramen of the backdalic, posterolateral, posterior hernia, eventration, that is the central hernia, and second is the acquired hernia. These may be occur due to the trauma or very rarely following operations involving the diaphragm. Esophageal hiatus hernia constitutes 98%, traumatic and post-operative are very rare. Traumatic hernia due to the rupture of the diaphragm is developed. Dear students, here is a picture showing the large defect in the diaphragm is showing, and hence the most of the small intestine goes into the thoracic cavity is clearly seen in this image. Another image showing the herniated diaphragm. Now the mediastinal syndrome. Compression of the mediastinal structures by any growth tumor gives rise to the group of symptoms, that is the obstruction of superior vena cava, pressure over trachea, esophagus, left recurrent laryngeal nerve, phrenic nerve and intercostal nerves, and pressure on the vertebral column. Now the next point of this lecture is the heart and the pericardium. First we see the pericardium is a fibroserous sac which encloses the heart and the roots of the great vessels situated in middle mediastinum. Heart dimension male and female is 12 by 9 cm, weight is 300 gram, and in the female 14 by 10 and weight is 250 gram, means the female's heart is greater than the male. Physically this is also shown in this anatomy. Position of the osculatory areas. Next I will show you the diagram of the osculator points of the heart. Now the cardiac arrest means the cardiopulmonary arrest, unexpected cessation of effective ventilation and circulation in a person. Dear friends, here is the image showing the cardiac circulation, the heart anatomy, pulmonary artery, pulmonary vein, mitral valve, aortic valve, both atrium and right and left and ventricles is clearly seen, and this is the pericardium. The cardia is covered by the pericardium, that is the pericardium. This is the pericardial sac in which the heart is situated. Now the sudden cardiac arrest. Now the pathogenesis. There are number of causes of cardiac arrest. One is anoxia, inadequate ventilation and tracheobronchial obstruction either from the retained secretions from aspirated gastric contents may cause cardiac arrest. Coronary occlusion of one or more coronary arteries with resulting myocardial ischemia and infarctions of the second common cause of the cardiac arrest. Third is the reduced cardiac output may also cause the cardiac arrest due to the marked decrease of cardiac output and rapid fall in blood pressure. Fourth is the electrolyte abnormalities, either deficiencies or excess of the potassium may cause cardiac fibrillation and arrest. And fifth is the drug. A few drugs when used in excessive amount are known to induce the ventricular fibrillation, even cardiac arrest, and that is the anesthetic drugs, inotropic drugs, isoprenaline, dopamine and adrenaline, quinidine, beta blockers. All these drugs. Arrhythmias, profound bradycardia with a great rate below 60 beats per minute may progress to ventricular arrhythmia with either fibrillation or arrest. Disease myocardium, it is a less severe and relatively minor disturbances may cause cardiac arrest. Reflex stimulation, with stimulation of vagus nerve which also supplies the heart, it may lead to cardiac fibrillation. Aberrant electric current, electrocautery may induce the cardiac arrest following fibrillation. Malfunction of the implanted pacemaker. Now the type of the cardiac arrest are ventricular fibrillation is the most common cause which lead to cardiac arrest. Ventricular fibrillation is usually associated with the diseased heart, myocardial infarction or with an irritable heart. Mechanical asystole. In this condition, the heartbeat becomes slow and feeble and ultimately stops. Circulatory obstruction. This is often caused by massive pulmonary embolism or accidental occlusion of one or main vessels. Now the pathology. 4 to 6 minutes of anoxia can be tolerated by the normal cell. Pupils begin to dilate in 30 to 45 seconds. After 1 minute, medulla oblongata becomes depressed. An adult can tolerate only 4 minutes of this sequence. This is the pathology behind the cardiac arrest. Now the diagnosis. The diagnosis of the cardiac arrest usually depends on absence of the carotid or femoral pulse. The radial pulse is not a reliable index for making this diagnosis. Always remember this. No cardiac sound, change of the color of the blood, dilatation of the pupils and loss of consciousness are the signs of the cardiac arrest. Now the ECG electrocardiographic changes cannot be wholly relied upon and electrical activity can persist long after the cardiac action has become ineffective. Treatment. There is a cardiac massage. First, which is the important initiation of ventilation, carotid pulse is palpated. If the pulse is absent, circulation is initiated by external cardiac massage. This is the accomplished by intermittent compression of the heart between the sternum and the vertebral column. This is the cardiac massage. And second is the ventilation to provide adequate oxygen in the prime treatment of the cardiac arrest. The airway of the patient is opened by tilting his head backward as far as the possible, placing one hand of the forehead and the other behind the neck. Third is the pharmacological therapy, which is important. Epinephrine, sodium bicarbonate, calcium chloride, atropine and lidocaine should be given immediately. Defibrillation. In the presence of the ventricular fibrillation, which can be confirmed by the direct inspection in case of the open chest cardiac massage or by the cardiogram, electrical defibrillation should be performed with the defibrillator unit. General capacitance defibrillation, that is the used today, is closed technique. In chest, electrodes are applied over the base and the apex of the heart. Now the fifth is the lateral management following the cardiac resuscitation is a steroid and fluid therapy. Fluid therapy should not be excessive. This may increase the cerebral edema. Investigations for heart disorder like the radiological investigation, standard chest X-ray. These give the information about the shape and size of the heart. Fluoroscopy. This indicates more precisely cardiac borders, contour and size of the various cardiac chambers. Then CT scan, more helpful in getting informations. Angiography by injection of the radiopaque solution of 30 to 70 ml of Niopan 370 under the high pressure. Ordinary angiography may be obtained with cut films. And next is the cardiac catheterization. The development of the cardiac catheterization can be separated into 3 major periods. The first period is the method where developed for inserting the catheters into the heart and measuring pressures of the various chambers. Second period is these techniques are where combined with the radiographic imaging to produce the various important information regarding the functions of the various chambers of the heart. In the third period, the catheterization techniques were modified and extended to allow the angiographer to treat the cardiac diseases as well as to diagnose it. And the fourth is the echocardiography, that is the cardiac ultrasound. Beams of the high speed ultrasound waves are directed through heart. When these waves cross a boundary or interface, the waves will be reflected back to the transmitting source provided the reflecting surface is at right angles to the original beam. Next is the radionuclear study. Radionuclear imaging has made a major advance in the understanding the myocardial function, both the health and disease. Magnetic resonance imaging, that is the MRI, with improvement of the equipment's technology, faster scan times and proper application, MRI is becoming the investigation of the choice in the patient of the congenital heart diseases. Now the types of the cardiac surgeries, this is the beyond the scope of the undergraduate students. That's why we are taking very short notes regarding these various types of the cardiac surgeries, like the extracardiac operations, closed heart surgeries, open heart surgeries like heart lung bypass, left heart bypass, femoral bypass, then regional shunts, hypothermia, surface cooling and venovenous cooling. These are the open heart surgeries. Now the congenital heart diseases. The scope of the cardiac surgeries have been increased considerably in the last decade. This has made it possible to operate on both the congenital and acquired heart diseases. Dear students, here is the image showing the congenital heart disease of the normal heart and double outlet right ventricle is clearly seen. Ventricular septal defect is there, double outlet is there, and this image showing the congenital heart diseases. Example, the hole between the loop heart chambers. This type of the congenital heart disease is called atrial septal defect, that is the ASD. It allows oxygen rich blood to the leak into the oxygen poor blood chambers in the heart. And second image showing the hole between the lower heart chambers. This type of the change of the congenital heart disease is called ventricular septal defect, that is the ventricular septal defect VSD. It causes the higher pressure in the heart or reduce the oxygen to the body. Now congenital heart disease, first is a cyanotic congenital disease and second is a cyanotic congenital disease. Cyanotic congenital disease is a patent ductus arteriosus after birth, that is the ligamentum arteriosum, coarctation of the aorta, extension of the fibrotic process of the aorta, arterial septal defect, secundum defect, ostium premium defect, and anomalous drainage of the pulmonary veins. Ventricular septal defect, all these are the cyanotic congenital heart diseases. And now the cyanotic heart diseases, here is a normal heart at the left side, and the cyanotic heart diseases, that is the tunnus arteriosus is clearly seen, arterial septal defect is there, ventricular septal defect is there. Now this is the pericardium. Now the cyanotic congenital heart disease. In cyanotic congenital heart disease, the patient becomes cyanosed very soon after birth. The most important and common in this group is the phallus tetralogy. Phallus tetralogy. Tetralogy of the phallus was first described in 1971 by Stensons, but little was understood until 1888, when phallus described clearly the combination of the abnormalities, and that is why this condition is called phallus tetralogy. The four main features combination of these abnormality constitutes the pulmonary stenosis, ventricular septal defect, dextroposition of the aorta, right ventricular hypertrophy, and the transposition of the great vessels. Now acquired heart disease, that is the mitral stenosis. This condition almost always due to the rheumatic fever through the definite history can be obtained in only 50% of the cases. Types of operation is closed mitral valvotomy, open mitral valvotomy, and mitral valve replacement. And second is the mitral insufficiency. It is usually rheumatic in origin. Other causes are bacterial endocarditis, rupture of the chordae tendineae, and papillary muscles dysfunction. For this, the porcini prosthesis is used. And third is the aortic stenosis. It should be remembered that the rheumatism has a predilections for the mitral or aortic valves, and open commissurectomy should be performed in this operation. Next is the aortic insufficiency. In the aortic insufficiency, the etiology is the syphilis, was a cause previously seen but not seen nowadays. Bacterial endocarditis, rheumatic fever, dissecting aneurysm, Marfan syndrome, and congenital aortic insufficiency is there, which as there is a left ventricular dilatation and hypertrophy in the aortic insufficiency, and treatment is the operation is usually advised. Next is the ischemic heart disease, that is the IHD. Atherosclerosis is the main culprit, and second is the disorder of the lipid metabolism such as the diabetes, hyperthyroidism, and hypercholesteremia. Surgical treatment is the coronary bypass operation and artery implants. Dear students, there is a type of the acquired heart disease: ischemic, hypoxic, hypertensive, infections, inflammatory, metabolic, nutritional, and traumatic. Now the pericardium. Cardiac tamponade, increase in the intrapericardial pressure secondary to accumulation of the fluid or blood in the pericardial sac due to the trauma or progressive effusion will yield pressure on the heart, which is known as the cardiac tamponade, and it produces a shock-like state, and if not relieved immediately may be prove fatal. The pathognomonic signs of the cardiac tamponade are increased venous pressure, and second is the decreased pulse pressure, pulsus paradoxus, and enlarged area of the cardiac dullness, subsequent development of the hypertension, and decreased heart sound. These are the pathognomonic signs of the cardiac tamponade. Now the pulsus paradoxus means the pulse becomes weaker on inspiration than on expiration. Aortic systolic pressure falls more than 10 mm Hg during inspiration. This is due to the normal inspiratory falls in the intrapericardial and right arterial pressure during inspiration. Treatment is the emergency. Treatment includes aspiration of the pericardial sac with an 18 gauge needle through the xiphocaudal angle. It is caused in cardiac wound. Immediate thoracotomy is usually required to repair it. And next entity is the acute pericarditis. It is in the children who are more oftenly affected nowadays usually younger than the 5 years of age. That is, the widespread use of the antibiotics has made acute pyogenic pericarditis is a rare disease. Now the pathological changes of this disease in the pericardium consist of the acute inflammation with increased pericardial vascularity and fibrin deposition. Clinical features of the acute pericarditis is the chest pain, most frequently symptoms. Pain becomes worse while lying supine and coughing. Investigation: chest X-ray, ECG, 2D echo, and the treatment is the medical therapy is first tried, which includes the bed rest till pain and fever subside. Non-steroidal anti-inflammatory agents such as aspirin and indomethacin should be tried to control pain. Appropriate perinatal antibiotics in the main therapy. If pain is not relieved within 48 hours, corticosteroid, that is the 60 to 80 mg of prednisolone daily may be given, and surgical treatment is the pericardial aspiration and instillation of the antibiotic is usually necessary. If medical treatment fails, surgical drainage of the pericardium is required if aspiration proves ineffective in controlling the disease. And for this, one should aspirate the pericardium by 18 gauge needle. And drainage of the pericardium, it is done making in the incision over the 6 intercalated space and mid calcareous line. And the third is, should exercise more than 3 square centimeter and send for histological examination. This image showing the conditions cause for pulsar paradoxus is clearly shown in single image. Next is the chronic constrictive pericarditis or Pick's disease. The etiology cause is unknown. Disease often represents end stage. Tuberculosis was considered for this condition. Traumatic hemopericardium may involve. It may be complication of the open heart surgery. Pathology: pericardium becomes thickened, fibrous and calcified. Treatment is pericardiectomy, sternotomy, incision should be taken, pericardiotomy and pericardial biopsy should be taken. Post-pericardiotomy syndrome, anti-heart antibody titers are sometimes raised. Dear students, here I take it in very short because this is more than enough for the undergraduate level of the medical students. If you want to know the detail about these points, you may refer the textbooks of surgeries and the specialists also. Here is the end of our surgery lecture number 103, that is the mediastinum, diaphragm and the heart and the pericardium. Thank you, students.